Dr. R. Ravindran sir from Chennai. Sir has done MD in General Medicine, DM in Cardiology. Sir is interventional cardiologist. Sir is working as assistant professor in Madras Medical College, associated with Res Clinic, Chennai. Moving to the next speaker of today's session, Dr. Bipin Chandra Aditya Dasari sir from Mysore. Sir has done MD in General Medicine, DM in Cardiology, DNB in Cardiology. Sir is interventional cardiologist associated with Manipal Hospitals, Mysore. Sir has done multiple publications in cardiological journals like the European Heart Journal. So with this, I welcome all the faculties of today's session and the delegates who are watching this live workshop. So over to you, sir. Sam Akbar, sir.
Good evening, everybody. Thank you so much for the kind words of introduction to all the speakers here today and also to myself. Very interesting topic to be discussed, no thrombosis. So even in the title itself, we have an interesting sort of title to discuss about. So thrombosis can be either arterial or venous, and many times the etiology is missed. And we've got various underlying causes, and we've got so many causes which we really don't investigate for. Many times we have a patient with us who's got a thrombosis, and then we're just chasing behind the reason why. And especially after our post-COVID scenario, we've got so many syndromes being unmasked just because of the hypercoagulable state which COVID has thrown at us. It's been a googly, and we've many times we've been stumped for answers. Young people coming in with thrombosis. In fact, a recent basic epidemiology study, it revealed that in the instance of DVT, 1 in 1 lakh pulmonary embolisms in children, incidence of pulmonary embolism in children is about 1 in 1 lakh unprovoked pulmonary embolisms, 1 in 10,000 in PH of people of reproductive age group, 1 in 1,000 of middle age group, and 1 in 100 for the elderly age group. So many a times we don't know. We're chasing behind different syndromes. We're thinking about factor V latent gene deficiency. We're talking about prothrombin C, prothrombin S, and a lot of other genetic syndromes. Many a time what happens is the diagnosis is it goes missing because the patient has already presented with a thrombosis, and we are left with only an post treated patient. And many a times we cannot even send a thrombotic profile because the patient has been treated with a lot of thrombolytics or antithrombotic agents, oral anticoagulants. We've got a plethora of drugs now at our disposal. We've got a good armamentarium of drugs to tackle thrombosis, but still long-term follow-up, how long do we give the thrombosis? All this needs to be looked into, and I'm happy that we're acknowledging that this is a big entity, especially those who are in a young, very much active age group between 30 and 60 are being affected. And we have to acknowledge the elephant in the room that we still, with regards to diagnosis and treatment, especially with regards to diagnosis and finding out the etiology, we are a little bit behind on that front, especially. But with regards to the treatment, quite a few drugs have come into the market, and we've been able to prevent further episodes of thrombosis. But many a times, the diagnosis and the basic etiology behind either whether it's arterial, we're able to identify whether it's arterial or venous, but many times the etiology goes a-begging. So some interesting cases to be discussed. I'm sure the speakers can shed some light on it. I'm happy to hand over the dais to the first speaker. Whoever is ready first, we can start. So we start with Dr. Siddharth.
Yeah. Hi.
Yeah.
Okay. So are my slides visible to you guys or not?
Not yet.
Okay, 1 second. Just hold on. 1 second. Hold on. I did share my slide. I don't know what happened. Should I just log off and log on again and just see what exactly is happening, or just hold on 1 second. Yeah, I did share my slides a little earlier, but I think yeah, okay. Hold on. Can you see my slide now?
Not yet, sir.
Yeah, now it's it's coming on.
I think what happened is that once they interrupted, no, probably it must have gone off. Okay. So here we go. 1 second. Right. Okay.
Yeah.
Right. So a 26-year-old female, married, comes at 3 a.m. with sudden onset of breathlessness. She's had a history of marital stress. ECG was not that remarkable. She was told that she has anxiety hyperventilation because of the stress, and then she comes back the next day morning with worsening breathlessness with a high respiratory rate. Now, even if you see the PCO2, the partial pressure of oxygen and carbon dioxide, both are on the lower side. Okay, so one point that was missed was that the patient was on oral contraceptive pills. She was basically on stress due to other factors. Anyways, so obviously she was diagnosed as PTE. By the next day morning, the RA and RV were mildly dilated, and the RV was slightly dysfunctional. So there's another case of a 68-year-old gentleman with a history of fatigue and atypical chest pain, intermittent wheeze, on inhalers with mild GERD. Now the thing was that this person was actually pretty much bedridden. So a VQ scan was done following that, which showed that he actually had there was a defect. So coming to the introductory slide now, that PT is a major cause of morbidity and mortality, and it can be masked by any other life-threatening disease. So hence it's known as a great masquerader. Okay, and this has been mentioned in Harrison's also. So the diagnosis is usually hampered by difficulties of moving patients, restrictions in the use of invasive techniques, and non-invasive tests are frequently relied upon in the context of high clinical suspicion. So majority of preventable deaths due to PT is due to an initial misdiagnosis rather than failed therapies. So majority of patients in the ICU have one or more risk factors, and 50% of patients with the proximal lower limb DVT and 20% with upper limb DVT have asymptomatic PTE. And PTE was undiagnosed during life and confirmed at autopsy in 20% of cases. This was presented in 2001 in a journal. So the overall incidence of DVT in patients not receiving prophylaxis is approximately 30% and 15% incidence of PT, of which 5% may be fatal. Right? So there's a spectrum, as you all know. There's acute, submassive, and massive, and mortality in massive with hemodynamic instability is about 30 to 40%. So it should be recognized early and treated. So there's shock, there is RV dysfunction, and the long-term mortality is that a quarter of them die within the first year. So how do you manage it? So there's an initial, there's an intermediate, and there's an extended treatment. So the initial treatment of venous thromboembolism would be that would you thrombolize or not? And following thrombolysis, put the patient on anticoagulants, preferably low molecular weight, with that is acute treatment, and then shift on to either apixaban, dabigatran, or endoxiban, and then there is extended treatment. So, right, this is the well scoring. Basically, this is for PT, but when a patient presents to you, there should be a high clinical suspicion based on the history. History is extremely important. And 1 second. And regarding the initial therapy, there's actually a positive. There's a positive of randomized controlled trials on which one should be preferred. We use alteplase mostly to thrombolize without heparin. So and basically after you thrombolize, then you have to put the patient on heparin. So this is the based nomogram for heparin which we follow based on the APTT, and the APTT should be done every 4th hourly. So after you thrombolize, you do an APTT, and then you see this. The other thing is patients who have a high bleeding risk, patients who have already had a PTE, who have before an IVC filter may be inserted bedside under ultrasound guidance or also under fluoro, right? So what is the diagnostic algorithm? Algorithm for a high-risk PT. So a suspected patient comes to us with hemodynamic instability. Obviously, you'll do an echo. You look for RV dysfunction. If there is RV dysfunction, I would say that this is a very high suspicion for thromboembolism. A lot of people wait on for the CTPA. Well, if you see a thrombus in the pulmonary artery, RV dysfunction, you can straight away go and thrombolize because this indicates a high thrombus burden. Next is, if there is no RV dysfunction, then search for other causes of shock or instability. So patients without any hemodynamic instability, okay, so then you have a low or high clinical probability. If there is a high clinical probability, then you go in for a CTPA, and there is no pulmonary thromboembolism on CTPA, then you don't investigate further. And if it is, then you go in for a treatment. If there is a low probability, then you go in for a D-dimer. If the D-dimer is positive, then you go for a CT pulmonary angiogram, and then based on that, you decide on whether to treat or not, right? So how about follow-up? Now regarding follow-up, routine clinical evaluation of patients 3 to 6 months is recommended. An integral model of care after pulmonary thromboembolism involving hospitalists, specialists, nurses, and physicians is recommended to ensure optimal transition from hospital to community care. In symptomatic patients with mismatched perfusion defects persisting on VQ scan beyond 3 months after or referral to a CT EPH expert is recommended after taking into account the results of echo, natriuretic peptide, and cardiopulmonary exercise testing. These are all class 1 indications. Further diagnostic evaluation in patients with persistent or new onset dyspnea after pulmonary thromboembolism is a class 2A indication, and further evaluation may be considered in asymptomatic patients with risk factors as a class 2B. So the follow-up strategy would be based on the on the probability scoring, and if there's a high clinical probability and there is either an elevated pro-BNP or the high risk factors for thromboembolism, then you go in for a VQ scan. Or if there's a low probability, then you suspect other causes. If no risk factors for thromboembolism, then you just focus on anticoagulation and secondary prophylaxis, right? So now, regarding the indications for newer oral anticoagulation, so all of us know that they're indicated in atrial fibrillation, DVT, pulmonary thromboembolism, and also to reduce the recurrence of DVT and pulmonary thromboembolism, and for prophylaxis. So this actually tells us where you prefer which oral anticoagulant. Based on the elimination, you would obviously not prefer apixaban in cases of renal dysfunction. We have a lot of studies regarding warfarin. Very few landmark studies comparing apixaban to warfarin. And apixaban, as you can see, there is just 25% renal elimination when compared to the rest of them. So now recommendations for acute phase of low or intermediate risk. So you'll initiate anticoagulation without delay, and if anticoagulation is initiated parenterally, you can use low molecular weight or fondaparinux. Regarding oral, you can start if the patient is eligible for a NOAC. You can start with apixaban, dabigatran, or rivaroxaban. Also, taking into other factors like age, bleeding risk, renal dysfunction, and hepatic dysfunction. So these are basically the trial designs regarding acute DVT and PE treatment, where there's the famous RECOVER trial, the Hoxsey VTE, Einstein DVT, and the Amplify trial regarding apixaban. The Amplify study design basically was to compare apixaban and warfarin. So it showed that apixaban had a lower bleeding risk, and it actually was good in preventing recurrent VTE when compared to enoxaparin plus warfarin. Right. So now, how about the extended and anticoagulation therapy? So you have whether it is a provoked or an unprovoked. So provoked, for example, suppose the patient had a surgery, was immobilized. So we had a patient with us who actually had a trauma. He had a trauma to the lower limb, and following that, he had a thrombus that got dislodged, and he had a pulmonary thromboembolism there. So that would also come under provoked. So you'll preferably give it for just 6 months. If it's unprovoked, you would actually consider for a longer duration of therapy. Okay. So prevention of recurrent DVT and pulmonary embolism, you have the Resonate trial, the Einstein extension trial, the amplified extension trial, and the Remedy trial. So this is just a brief summary of them. And in the amplified extension trial is basically a double-blinded trial where you start off with apixaban and versus there's 2.5, 5, and placebo for patient who were confirmed DVT, who had already completed 6 to 12 months of standard anticoagulation. So they actually they went ahead with an extended treatment, and they found that that the extended treatment was actually pretty helpful when compared to placebo. There was definitely a lower recurrence of pulmonary thromboembolism, and the safety profile was almost the same. Right. So the number needed to treat, that is to prevent one recurrent VTE, was 14, and the number needed to harm was 200, which goes in favor of apixaban, the lower dose 2.5 actually. Right. So this slide tells us that this is a comparison. Okay, in patients with extended VTE treatment regarding recurrence and bleeding, which showed that apixaban was almost equal to rivaroxaban, but when it came to bleeding, apixaban had a very low risk when compared to dabigatran and rivaroxaban. So as you can see in this slide, mind you, rivaroxaban was the extension, that is the Einstein extension, and Resonate was dabigatran, and Amplify extension was apixaban. So the 2020 guidelines say that you first diagnose it, then you have the initial treatment, then you have the primary treatment for about 3 to 6 months, and then you have to make a decision regarding stopping anticoagulation or continuing for secondary prevention. That is, whether if it's an unprovoked DVT and the patient has a high, suppose it's a provoked DVT with a patient with a high bleeding risk, you'd obviously just stop it over there and then ask for a regular review. The NICE recommendations say that the patient is without any comorbidities, you do offer continued treatment with the current anticoagulant if it is well tolerated, whichever DOAC it is, and if the current treatment is not tolerated or the clinical situation of person's preferences have changed, then consider switching to an alternative. And if the patient has comorbidities, then consider carrying on with the current treatment if only if it is well tolerated. That is, what are the comorbidities you'll be looking for? You'll be looking for whether there's any renal impairment, any active malignancy, or the patient is of low body weight. And DOAC should not be used in patients with a history of thrombosis who are diagnosed with antiphospholipid antibody syndrome. Right. This is the definition of the fragile patient. And with renal dysfunction, very few trials, hardly any landmark trials regarding apixaban, but it is theoretically at least safer in patients with renal dysfunction. Right, so this slide just tells us the mechanism of NOAC-related GI bleed, which is seen probably more commonly with dabigatran, where there's inhibition of mucosal healing, incomplete absorption, and direct caustic effect. Right, so in the major pivotal trials, it showed that apixaban had a lower risk of GI bleed. Right. in most hospital deaths is an initial misdiagnosis, and appropriate prophylaxis significantly reduces events and mortality. And in patients with strong clinical
Sir, your voice is not coming, I think. Siddharth, sir. I think because of the network, poor network, sir got disconnected. Sir, you're there?
So far, he's summarized everything quite well. So far, he's just, I think we've lost his connection just at his penultimate or last slide.
Right, sir.
So he's covered, as we've already established, that the initial diagnosis being missed, he's covered that point quite well. Many a times we don't find out, and we just go ahead and treat, and the initial diagnosis always goes a begging. And we're left with the option either to do a short course of therapy for 3 to 6 months, or extend the course of therapy for up to a year. Interesting that he noted the safety of apixaban being much better than the other two, dabigatran and rivaroxaban. And he had touched upon the number needed to treat being 14, and the number for adverse event being to happen was up to about 200. So yeah, risk versus benefit ratio, apixaban, especially in case of an elderly person, low with maybe a very fragile person who has high creatinine, more than 2, and low body weight, less than 50 kg. All these we can reduce the dose to 2.5 BD, and we can have a safer sort of outcome than dabigatran at a full dose, or a rivaroxaban at a full dose, especially with regards to GI bleeding. I'm sure that we will discuss about venous thromboembolism. I'm looking forward to discussing about the other spectrum being arterial embolism as well. We can have our next speaker, either Dr. Ravindran or Dr. Satyamurthy, whoever is ready.
Present, sir, Dr. Ravindran.
Yes, sir.
Yeah.
Good evening. Nice to have you over here, sir.
Yeah. I think Sir has to unshare the screen to share. I think, hope you are visualize my screen.
Yes. Quite clearly, yes.
Yeah. Yeah. As you said, Sir has been extensively covered about an anticoagulants and other things in pulmonary embolism. I'm not going to much about the theoretical part. I'm just here enlightening. There's few two cases about a coronary thrombosis. I think Sir has been got connected again. I think we can. We can just inform the Sir, or we will continue the presentations.
Siddharth, sir, you can unmute yourself. Are you?
Audio is there. The sir's audio is not connected yet. I think they're connecting the audio.
Okay.
So I will just show the two more cases in the arterial thrombosis. When I think next we will go upon in detail about and all other thrombosis and other things. Just I wanted to. Not able to share actually the screen. Change the slides. Are you able to see my first slide?
Yeah, your first slide is visible, sir.
Yeah, I think Sir is trying to change our. I don't know.
Yeah, sorry. I sorry to interrupt. I'm sorry it got disconnected. Were you guys able to follow, or halfway through it went away?
It went away in your last slide, your summary, We were stuck with your summary, so we read it.
Oh, okay, fine.
Siddharth, sir, if you have some more to share with us, you can continue.
No, it's okay. It's okay. Thank you. I'm actually kind of tied up here. I was just searching for a cab to go back home. Okay, thanks.
All right, sir. If it's okay, then we can continue with Dr. Ravindran's slide.
Yes, please. Yeah.
Sure, sir. Ravindran, sir, you can continue.
Yeah. Are you able to see my slides, sir?
Not yet, sir.
Now?
Now it is visible.
I will straight away go to the slide and videos.
Yes.
Now you're able to see?
Yes, sir.
Yeah. This patient was a very younger age group, 42-year-old male. Now you could able to see the clean RCA of this patient. But just before this check angiogram of after 1 week, you could able to see the RCA was totally cut off. This gentleman presented with an inferior RVMI. We have been planning to take for a primary angioplasty. And we have did an angiogram and found to be that completely RCA cut off. Initially, we thought it was an CTO, but after putting in wire, we were able to see the distal and PD and PLB, but could not be stented. So what we did was we didn't thrombolize the patients after the angiogram. The second angiogram was done after 1 week with an complete anticoagulant of low molecular heparin and an antiplatelet with an ticagrelor 90 mg BD and with an aspirin of 75 milligram. Just now, I want a little bit enlighten about that. These thrombosis can be completely occluding and present as if we cannot do anything, but the drug can still revert to the normal levels. We could not even imagine that the effect of the thrombolysis and an anticoagulant drugs can cause a completely normal right coronary artery actually, even in treatment of only 1 week. I'm sorry for the bad cropping of these videos. I'm just being hurry up in present making these videos. And next, the similar case I want to present. This was this gentleman was presented with a non-ST elevation MI, and we took an angiogram. You can able to see the LED, which was completely thrombused, and the LED was like an aneurysmal segment from proximal LED to the mid part of LED. We are not able to see completely the LED, but the left circumflex artery and other systems of RCA seems to be normal. You can just see the LED with complete thrombosis from an LED. The same as it was in presentation of end-stelling, we didn't realize the patient. We put on a low molecular heparin and same anticoagulant for 1 week along with an aspirin 75. You can see the check angiogram we did, and after 1 month of treatment, you could still see that there was a slow flow in LED, but there was a complete resolution of the thrombus which was presented earlier. But this patient also, we didn't do any stenting or anything, even though the previous patients we could have been put in stent, but this particular patient, stenting is also not possible, as there was a proximal and distal disproportion of the vessel with aneurysmal segment was there. So with this 1E2 case presentation, I just wanted to enlighten that still we have a more and more effect of thrombolysis, anticoagulant and antiplatelet level. The drugs can do still more even in this present situation of a primary angioplasty and interventional stages where we can put most now the lot of intervention has been occurred, like we can go put an OCT, IVS guided, and then ROTA, everything. But still, even the areas where our intervention cannot penetrate, still we have our oral anticoagulant and thrombolysis have a major effect. With this, I will stop my presentations and we will discuss about the effect of the drugs in final discussion like this. Thank you.
Ravindran sir, that was excellent. Those two cases were an eye-opener. In fact, we've been discussing at length Do you have a few more slides to share, or is that
Yeah,
pretty much it?
that's all. I just wanted to just show that the drugs have a more effect on thrombosis, but still
Fantastic, sir.
we are thinking about that. We will do some intervention there and putting a stent. We can recanalize and bring back the vessels to the normal level. But the areas where we cannot able to negotiate also, we will be able to depend upon the drugs. In that situations, if you put the drugs for even a 1 week and come back to the previous same patients, we could see that there was a complete resolution of thrombus. So what my idea of this putting these two cases was that like still the drugs can do much more better than our present interventions. That's it.
Absolutely, sir. Bang on. I think a lot of wisdom and a lot of thought has gone into your presentation. You've selected two very good cases to discuss here today. And this again reinstates the wisdom behind a pharmaco-invasive model.
Yeah.
Especially if you have a hub and spoke sort of scenario. You have a early presentation. It also counts as how early the patient can get to your center and how early you can thrombolysis before the plaque, before the thrombus becomes a hard thrombus. If you're able to thrombolyze within 60 minutes or within 120 minutes or within at least 6 hours of the presentation, we can give a good thrombolytic therapy and a good drug therapy. Many a times we can avoid a stent, which again, a stent, no matter how much we try and push down, it entails a lot of precision work. It can also predispose the patient to further complications like a stent thrombosis, or you might have a dissection, you might have multiple stents being put in. Again, your thrombotic burden also will increase. I know a lot of people, especially in our current scenario, we want to push primary angioplasty as the first and the gun therapy for all acute STEMIs. But the knowledge and the wisdom behind a pharmaco-invasive therapy, even to reduce the thrombus burden in a case of STEMI, many a time it is a lot easier to go in with a pharmaco-invasive therapy after you've lysed the patient with a good thrombolytic agent like tenecteplase or streptokinase even. And then after that 6 to 8 hours or within the first 24 to 48 hours, go in and go ahead with a rescue PCI sort of strategy. I think that especially in our scenario, it provides a lot of wisdom. And I think both these cases have highlighted that phenomenon. Also interesting to see that you've moved on and used an oral anticoagulation with aspirin for at least 1 week, and then gone ahead and done a check angio and seen a good result. Wanted to know how long you continue this rivaroxaban or whatever, an oral anticoagulation with aspirin in such sort of scenarios.
Usually, the guidelines, according to guidelines, there was no particular durations or usage of anticoagulant in these patients. We have used only newer antiplatelets like ticagrelor for 90 milligram BD with an aspirin of 75 milligram OD. The initial first patient we have been started just now. He's a young 40-year male, 34-year male. The second one was a 42-year old. Both these patients has been now without a metal lake, as you said, without a stent. But one patient I have stopped an antiplatelet also from dual to single antiplatelet and after 1 year. And one patient just now they have been on a dual antiplatelet.
Okay, sir. And this young STEMI, a young patient presenting with STEMI with maybe, I'm not sure what you had not mentioned, whether they had any comorbidities or risk factors for thrombosis.
Only stress was the risk factor. He doesn't have any risk factor. Like he said, he's non-smoker, non-alcoholic, non-diabetic, non-hypertensive. He just had some severe stress like some relationship failure and that made him to loss of sleep for 1 month, and suddenly he got an MI with an inferior MI. It was surprised to see that even a stress can cause within 1 month this much of an acute inferior postural MI. As you mentioned, only as we are presenting in a tertiary care center and the patients could reach the hospital very earlier before the patients been thrombolized within a tertiary care center or some other where before doing an angiogram, if they thrombolize, the entire scenario we may not be able to find before and after how it was with an angiographic evidence. So as they reached the tertiary care center, we could take them as a primary and check the angiogram. After treatment of 1 month or 1 week, we could able to check the repeat angiogram so that we can say boldly that you can just have the drugs for a remaining period. And also they are not having any other lesions in other two vessels.
Yeah, that is also a very good marker, so that this doesn't entail a chronic coronary syndrome. It's an acute thrombotic event.
Yeah.
And even if you see the lumen of the vessels, it's quite clean. It's clear.
Clean.
It doesn't have any calcification. It's not like a chronic event. It's just an acute thrombus. It leads me to think again that maybe we're missing a trick when we think of stress cardiomyopathy, Takotsubo cardiomyopathy. It could be because of an acute thrombus, because of stress related event. And then we are seeing the patient once the coronaries are recanalized. It could be a hypothesis, but still we don't know. Again, diagnosis goes a begging. We're thinking, okay, we can't just quantify stress. There is no specific, even a questionnaire cannot quantify stress. So we don't know what we're dealing with again. But kudos to you and your team for not going ahead and being over enthusiastic and stenting a difficult vessel and then coming out of a difficult scenario. You waited, you thrombolized, even though you had a reason to stent. Many a center would have gone ahead and stented that. You thrombolized, you reduced your thrombus burden, and you did take a check shot after some time, after 1 week. I think that was a prudent move at that point of time.
Yeah.
Thank you, sir.
Yeah, thank you.
Bipin sir, nice to have you on board.
Same here. It's a pleasure. So, yeah.
Sure, sir. So we can have your presentation as well. And are you in Chennai for the conference, for the CSI conference?
No. I was not in Chennai. Actually, okay. I came for a class which Dr. Anantharaman has done recently. So on TAVI at Kaveri, so I couldn't afford to look more time.
Sure, sir.
Can you see my slides?
Yeah, we can see your slides.
Okay. So, just a second. So, good evening, everyone, and thank you for having me here. On this onset, I'll take this opportunity to thank our patients who suffer so that we can learn from them and make the treatment better in entirety for the entire population. So today I'm going to talk about a case which we had few months back, 3 months back, if I'm not wrong. And the patient is still suffering. So I'm going to discuss about that. So let us talk some things about triple therapy when it is too much. So thrombotic risk and the bleeding risk is always a tightrope on which the patient walks on. So the sad part is if the patient is a high thrombotic risk, there are high chances that the patient is also having high bleeding risk, because all the risk scores for both thrombosis and for bleeding, they overlap so much. And we'll be left with an option. We won't be left with an option which is not as clear as night or day. So a lot of gray area which needs to be assessed. So the bleeding risk assessment, according to me, is always an illusion because we don't know what exactly, and it just hits us like a stunner and we will be stuck there in patient care. So this is a 74-year-old gentleman who had an acute coronary syndrome with tropi elevation. He had rest chest discomfort and dyspnea for 48 hours before presentation. And he is a diabetic and hypertensive. He has undergone bypass surgery 10 years back. He has ST depressions in inferior leads and lateral leads, and his LV function was normal. His creatinine clearance was 95. So, yeah, we have done a coronary angiogram which showed patent lima to LAD, and no other grafts were visualized to RCA territory or to LCX. But left main to LCX has a critical stenosis. I'll show you the pictures in the coming slides. The procedure was done with a 4 by 33 mm drug-eluting stent and good flow. The result was very good. So it's quite a critical left main distal and ostial LCX stenosis. So this is the final result. And we are happy with the result, and patient is relieved of his symptoms and he's shifted to ICU. So post PCI, he is hemodynamically stable. His symptoms disappeared. He's discharged on day 2, and he's discharged on dual antiplatelets, 90 mg of ticagrelor twice a day and aspirin 75 mg once a day. So on the 6th day, patient came back to us He came with sudden onset of breathlessness, no chest pain. We have done a troponin, suspecting some acute event within the stent, but the trop was only marginally elevated. It's 0.028, where our lab reference level, the upper limit is 0.023. But his SATs were on the lower side. It was 83. So we got an ABG done and PO2 was 55. Borderline hemodynamics, he's having systolic BP of 90, but with little fluid and little inotrope, he recovered from that. But we had high suspicion of pulmonary embolism. So we got a CTPA done, which showed left distal pulmonary artery and bilateral lobar and segmental artery thrombosis. I'll just play that for you. So here, yeah, can you people have can see the thrombus here? So then, what are the challenges and the options we had in this case? His Hasbled score was 2 to 3. Should we add a NOAC and observe, or just anticoagulate him with low molecular weight heparin or regular heparin and just wait on it? Or do a catheter-directed therapy because his bleeding risk was on the higher side? We wanted to do a catheter-directed therapy, but the patient attenders denied, and his SATs were still in the level of 80% on room air. So we have given a tenecteplase injection, 30 mg, and patient stabilized hemodynamically, and he came off oxygen, and he is good within 6 hours, 6 to 8 hours after the thrombolysis. So patient was discharged on day 3. He is asymptomatic, feeling well, went home. So we have put him on triple therapy with aspirin 75 mg, and we have reduced the dose of ticagrelor to 60 BD. And he's on rivaroxaban 15 mg once a day. So 2 hours post-discharge, the attender calls us and he tells that patient is having a heavy head and epigastric discomfort. So we asked him to get him back to ER immediately, and he is drowsy. He has coffee ground colored vomiters, and he has a large intracranial bleed with mass effect. He has a very significant upper GI bleed with a HB drop of almost 2 grams. And hematuria. So he's bleeding from everywhere. So this is what the neuroimaging showed. So you can see a huge bleed with mass effect. So then we went to rescue the patient. So we have given all epsilon aminocaproic acid and fresh frozen plasma and platelets. But in spite of that, the intracranial hematoma kept expanding and a burr hole was done. His hematuria and GI bleed stopped within a day. And from day 3 onwards, patient was still drowsy. He obeys commands and he has spontaneous respiration, but he's never back to his original state. So after that, the neurosurgeon was not very keen on starting antiplatelets after the procedure. So we started antiplatelets only on 19th day, on 20th day. So then also we started him only on single antiplatelet, that is aspirin. He has no coronary event. His AF was all right, no new regional valve, and he has stable hemodynamics. His sensorium more or less remained the same just after surgery and even on the 20th day. He's still in a neuro rehab center. So yeah, he's still suffering. So for the discussion, what is the culprit? Is it the aspirin, ticagrelor, tenecteplase, or rivaroxaban? If it is tenecteplase, why didn't the bleed happen on the day of thrombolysis or 3 days till 4th day? He was quite all right. So yeah, and how to deal with these patients who have a high thrombotic risk and a high bleeding risk. So I attended a symposium recently on this HBR. So there I was introduced to this ARC HBR app, which they have designed for both iPhones and Android. So which gives us whether the patient is a HBR patient or not, and it tallies between the ischemic risk and the bleeding risk. But the irony is, most of my patients who are having high bleeding risk, and I'm suspecting high bleeding risk, are of high ischemic risk also. So I think we have to shed more light in future studies on these kind of patients so that we can help them even better. So thank you.
Thank you, Vipin. Interesting discussion. And definitely, I wish all the best, all the very best to the patient. I hope he recovers and comes out.
Yep.
You guys have done your level best and you have documented everything so beautifully, including showing us in detail with regards to the radiology. So, what do you think? I don't know. I mean, every one of them points towards a different, because rivaroxaban, aspirin, anticoagulant can all cause GI bleed.
Exactly.
And intracranial bleed, TNK can cause. I've had a couple of patients bleed into the brain because of tenecteplase.
Yeah.
Hematuria also because of tenecteplase, but that all this occurred 72 hours after the tenecteplase was given. So again, I wouldn't think that tenecteplase would stay in the bloodstream for so long.
Yeah, that's a point of discussion, and that's the confusion, because what all we did in this particular patient is to help him to tide over the acute crisis. But unfortunately, he is still in a rehab center even today, a neuro rehab center. So yeah.
True. He was 70, you said, and he was 74. So could you have thought of using apixaban instead of rivaroxaban?
Actually, his clearance was quite good. That's the only reason we have gone with rivaroxaban. We could have gone with apixaban too. Apixaban also.
Ticagrelor, what was the rationale behind the ticagrelor?
No, we have, since the patient had a non-ST elevation MI or an acute MI, that's the only reason we have loaded him up with 180 mg of ticagrelor, and we have taken it for the procedure. And nowadays it has become a standard operation practice for us that we give any primary patient coming to us, unless otherwise who had a bleeding history or something like that, we are starting them on ticagrelor right away. And we had this doubt about ticagrelor also, and that's why after he had this pulmonary embolism episode, we have reduced the dose also to 60 mg. Okay. But yeah.
Yeah, high bleeding risk, HBR. I also need to update my Android phone with that app. Definitely, it's something which we all need to keep in handy.
Yes, yes.
Many times
nice interface. It has nice interface backed by very good evidence. It is called as ARC HBR. You can just download it.
Sure. Thank you. So definitely a take-home message already delivered. We'll definitely incorporate that in our practice.
Thank you. Thank you so much.
So nice, lovely, interesting evening. Good short presentations, good discussion, and we had a detailed discussion from Dr. Siddharth as well. I think he has exited the chat room, the Zoom. But to summarize, I think we've covered on all the drugs. We've spoke about oral anticoagulation and the need for it to be at least 3 to 6 months, and then whether we can extend it to up to 1 year. We've established Siddharth sir also spoke about how safe apixaban is. It has a lower risk of bleed, as evidenced by the extended Amplify trial. Ravindran sir, you gave an amazing presentation with your 2 cases, brief yet very insightful and thoughtful. How to avoid a stent, how to avoid when you have high thrombotic burden, how you can still rely upon thrombolysis as an initial approach, and evidence that the pharmacoinvasive therapy in our setting, it still holds a very important place. Also, early presentation and lysis in a peripheral center within maybe 0 to 60, 0 to 120 can really benefit a patient, and then take him for an angiogram subsequently. And also, don't jump the gun. If you have a very high thrombotic burden in your angiogram, think about again thrombolysis, and then keep him on an anticoagulation for at least a week or so, and then recheck the angiogram if the patient does not resolve. It takes a lot of guts to do such things. We can think of doing such things when we have good backup and a good strategy with us. Suppose if the patient doesn't resolve, we can still take for a rescue PCI patient. We can still pass the wire and try to resolve the thrombus. All these things are possible when you come to a tertiary care center. In the periphery is always a pharmaco-invasive therapy is a tried and tested method, and you can always shift the patient by yourself. Sometimes shift the patient and also make the job easier for the interventional cardiologist because you're reducing a lot of thrombus burden, and you're giving him a prepared vascular bed where he doesn't have to struggle and in the middle of the night. Oftentimes it's the youngest, most junior interventional cardiologist jumping for an angioplasty just because he's getting a chance to scrub. He's going to go jump and do something. And I think many times it's better that you wait and you involve everybody. It's not just a simple, they say it's a soft thrombus, but many times we've lost patients just because of over enthusiasm. And also with regards to Bipin sir, amazing. It was nice to that you disclosed a difficult scenario, less talked about scenario where we have a bleeding risk. Many times we just want to focus on our successes, but sometimes our failures teach us a lot more. So we have to treat both those scenarios, both success and disaster, as just the same, and then take evidences from each episode and then go forward and move to the next case so that we can do better and treat our patients. At the end of the day, we want to see them recover and go home happy. So lovely evening. Thank you, MCure and Vikrant, for organizing this. I hope we survive the storm in Chennai and come out of the cyclone. And I hope to meet all of you friends maybe in the next CSI in Kolkata.
So we'll catch up at India Live.
Oh yeah, Chennai in March.
Yes,
yeah,
yes.
We'll meet then.
Sure. And even Sentient Summit is coming up in March.
In March.
So either of the meetings will catch up.
Sure. Where is the Sentient happening?
Sentient, I'm not sure. Dr. Sai has not disclosed the location yet. It will soon come up. By Jan 1st, I think the venue will come up.
All right.
Sure, Doctor. Thank you. Thank you so much.
Thank you. Thank you, sir.
Thank you, Dr. Sama Akbar sir, Dr. Ravindran sir, Dr. Bipin sir, and Siddha sir, for this very, interesting cases and the insightful discussion. I am sure all the viewers, who are watching this live workshop, would be, delighted to have this nice interaction on the insightful interaction on interesting cases. So, see you with the next series of this live workshop in next month, sir.
Yeah, thank you.
Good night.
Good night.